My name's Dr. Mark Valenti. I'm an orthopedic spine surgeon. My office is just a mile down the road, one of them. And I really want to thank everybody for coming tonight. I think this is a topic that a lot of people, a lot of physicians and practitioners, they see people with back pain all the time. So hopefully it's applicable to pretty much everybody in here. A little bit about myself. I grew up in Michigan. I went to medical school in Florida, Nova Southeastern University. Just met another grad back there, which is great, another alumni. I did my orthopedic surgery training at Michigan State, and then I did my spine surgery fellowship at the University of California in San Diego. I was pretty fortunate during my training because I was allowed to go to other facilities to get other spine surgery training. So I went to the Hospital for Special Surgery and Thomas Jefferson University in New York and Philly, respectively, which are top-notch institutions for spine surgery. So I really got a really broad experience seeing everything from complex reconstruction, deformity, revision surgery, all the way to the most advanced minimally invasive techniques. So I really grabbed from all these different institutions all over the country to give myself a big armamentarium of treatment options for my patients that I think have really helped me and helped the patients because I can offer them not just minimally invasive, but also reconstructive complex deformity surgery as well, just depending on whatever the patient needs. I can really tailor it to their specific problem. Just a brief overview. So first, we'll talk a little bit about anatomy, a little bit about some signs and symptoms that patients may have when they show up. Some of the signs and symptoms are sort of subtle, and a lot of people won't even relate it to spinal pathology or spinal cord pathology. So we'll talk about that a little bit, and then we'll talk about some imaging, MRIs, and go over some things that you might be able to pick up on an MRI, some very common things also. And then we'll talk about some treatment options, obviously conservative treatment and surgical options, and the newest minimally invasive techniques that are being employed today. So back pain in general, 85% of people in the United States will have a significant and severe episode of back pain requiring them to either take pain medications or go to see their doctor. That's a really high number. 15 million office visits every year are for back pain. It's the fifth most common reason for a patient to be admitted in the hospital. So there's a lot of patients experiencing it and a lot of patients seeking care from us for this problem. Systematic approach. So I'm very systematic in my approach, as I'm sure you guys are too, because we're less likely to miss things if we're that way, right? So the history is, where's your pain? Where's your numbness? Where's your weakness? Is it in the back? Is it in the legs? Physical exam, motor exam. I want to test muscle strength, sensory, reflexes. Imaging, x-rays. I'm doing dynamic x-rays, flexion extensions, looking at the MRIs. So everything's the same, systematic every time. So patients that come in and see us, so what are they going to present with, right? Well, so it's common, obviously, if they have back pain, it's okay, that's pretty straightforward. But maybe they have leg pain, or maybe they have numbness or tingling in their feet, and then we're not quite sure, well, is this a vascular claudication, or is this a neurogenic claudication? Is it diabetes, or is it stenosis in the spine? They may have reflex changes. They may have muscle spasm. They may have limited motion, sensory deficits. So there's 24 vertebrae in the spine from the base of the skull to the sacrum, right? And we have discs at each level. And we have nerves that run out at each level bilaterally. It's really important to know your dermatomes when you're trying to relate your findings on an MRI to a patient's history, where their pain pattern is, and where some of their physical exam findings are. So for example, in the upper extremities, we have C4 dermatomas up by the shoulders and 5 on the lateral aspect of the upper arm. 6 is the radial aspect of the hand. C7, the middle finger, and the ulnar aspect of the hand is C8, right? So in the legs, we have L2 and 3 on the anterior thighs. L4 oftentimes will wrap around the knee. So a lot of times some people might confuse that. Patients will point at their knee and someone might think, oh, they have a knee problem. They have some osteoarthritis in the knee or an internal derangement of the knee, maybe a meniscal tear. But really, it's a dermatoma L4 pattern, and actually that travels down typically at the anterior aspect of the lower leg or the medial aspect. L5 on the lateral aspect of the lower leg or the great toe. L4 is also commonly on the dorsal aspect of the foot, and S1 down the back of the leg or the plantar surface of the foot. So these are all the sensory dermatomes, right? And then, the muscles, we got L4, typically is dorsiflexion, tibialis anterior. L5 is EHL, the great toe, picks up the great toe, right? So I test the weakness for dorsiflexion of the foot for L4. Make sure they can bring up their great toes strong for L5 and plantar flex for S1. The easiest way to do that, a lot of times you can be tricked. You can test somebody, you can say, okay, pick your foot up, and you test the muscle strength and you push down. They feel pretty strong. Or you say, what I commonly tell people to test their plantar flexion, I say, push on my hands, push down like you're pressing on a gas pedal, right, to get them to push. But oftentimes if I feel, even me, and I do this 30, 40 times a day for 10 years now, it's hard for me to pick up subtle weakness. So a good way to test for subtle weakness is to have people walk on their toes or walk on their heels. If somebody's got a foot drop, they're not going to be able to walk on their heels. So that's a really good test to do. So imaging. A lot of times patients come into my office and I have them get x-rays. All new patients, they get dynamic x-rays, flexion extension. If they already have flexion extension, then I don't. But typically, 9 out of 10 patients will not have flexion and extension x-rays. So they'll say, I've already had x-rays. The ER did it, the primary care doctor, the chiropractor, they did x-rays. But for me, they have to have flexion extension. So that's really important. And so I train my staff to explain to the patient so they understand why they're getting these special x-rays. So what I'm looking for is instability, spondylolisthesis. I'm looking for a slip. If you just take an x-ray, a lateral x-ray in a patient's spine, a lot of times it looks aligned normally. There's no slip. There's no anterolisthesis. There's no retrolisthesis. But as soon as you have them flex forward and shoot an x-ray, or you have them extend back and shoot an x-ray, now you see a slip sometimes, right? So that's what I'm trying to catch with the dynamic x-rays. The next thing I do, if it's indicated, if they've been having symptoms for greater than 4 weeks or they have some sort of neurologic finding or deficit, is an MRI. So that's the gold standard when you're assessing spine pathology, is an MRI. So when do we get these other scans like CTs or CT myograms? Well, if they have a contraindication to an MRI, for example, they have a defibrillator or a pacemaker or a spinal cord stimulator or a pain pump or things like that, big metallic implants, those are contraindications at this moment in time for an MRI. So in those instances, what I get is a CT myelogram. So not just a CT. CTs are good to assess bone, as we all know, but they're really not that good at assessing nerves and neural impingement and herniated discs. If it's a really good scanner, you can get a broad sense of if someone has severe stenosis. But for what I'm trying to decipher between, you really need a myelogram added onto that CT. So if they have a contraindication to the MRI, I get a CT myelogram. The other time I would open is if they've had prior surgery with instrumentation, with screws or rods or cages. Because in that case, I'm assessing for fusion with the CT, but they're having some new symptom or something's going on. So I want to add on the myelographic component to see if they have neural impingement as well. So we'll just go through some MRIs, some basic diagnoses, some basic pathology of, that you might see on a general MRI. So when I look at an MRI, the first thing I do is I go to a sagittal T2. So when I was in medical school, I'll never forget that someone, you're trying to remember between T1s. Which one's a T1? Which one's a T2? You can't really remember. So someone told me one time, they said T2, so 2, H2O, right? H2O, water. So the 2, water, or T2, the CSF for the water is bright. So on a T2, water's bright. So that's how I always remember when you're looking real fast and you're like, you want to look at the bright one where the CSF is bright because it's easier to pick up if a nerve is being impinged upon, if there's stenosis, or if there's an intracord tumor or something like that, which would be pretty rare. So I look at a sagittal T2 because it gives me a quick snapshot. It'll show, if there's severe stenosis, you're going to see it on that sagittal T2. Now, if there's a focal herniated disc and it's off to one side, and you're just looking at one slice sagittal, you may completely miss it. So you can't just rely on the sagittal. But that's how I get my quick snapshot, because I'll see severe stenosis, I'll see if there's a disc that's totally crushed or degenerated, and I'll see if there's a big spondylolisthesis. So I look at that first. Then I go to my axials to drill down, for example, on each level to see if there's stenosis or if there's a herniated disc off to one side. Or the other thing I'm looking at a lot of times is these facets back here. So if it looks like a ram's horn, if this starts to look more like a ram, like see how this is sort of more oblong and extended, that's a sign of a more arthritic or spondylotic facet joint. What we might refer to, or you might see on an MRI report, is facet arthropathy. So in a little more basic anatomy, these are the vertebral body, obviously, the pedicles here, transverse process, facet joint. lamina is here. The lateral aspect of the lamina is the pars. So the pars is actually the weakest part of the vertebrae. And that's where often people will fracture through the pars. So you may hear of pars fractures. Now, pars fractures can be acquired many different ways. Some of them are congenital. People are born with them. Some of them are traumatic. Some of them are degenerative. So you can be caused by tumor or infection even. So herniated disc. Here you got a big glaring herniated disc at L4-5. So you can see a big bulge there. Again, the sagittal, quick snapshot. That disc is so big, that slice, probably all the slices in the sagittal are going to pick up that disc because it's so broad. Here you go to an axial, and you see the nucleus pulposus is the more gelatinous material in the center of the disc, and the annulus fibrosus, the outer rim. You can see what happens typically is the annulus fibrosus weakens, and the nucleus pulposus squirts out, and it hits the nerve. And that obviously causes pain, numbness, tingling, weakness, and reflex changes. So here on the left side there, you have what is a normal axial slice. So you can see these little dots are the nerve rootlets, okay? And then at this level, we have the neuroforamen. This light right here is the fat in the foramen. Foramen means opening. So here's the opening for the nerve. And this dot right here and here, that's the dorsal root ganglion of that exiting nerve. So this is L5S1. I can tell because I see the iliac crest here. So I know this is probably L5S1. So this nerve root exiting there is probably L5. And these nerve rootlets here will coalesce to create the S1 nerve root. Here you see the same, basically a similar cut through L5S1, but you got a big herniated disc back here. And you can see how this disc right here is pushing back on these little black dots, these little nerve rootlets, which are eventually going to coalesce and create the S1 nerve root. So I would venture to guess if this patient is symptomatic, they would have deficits or symptoms in an S1 distribution. Degenerative disc disease, so this is very common. There's a general rule. The general rule is that if you pull 100 people off the street, okay, and you do an MRI scan of them, patients in their 40s, 40% of those patients who you run through the MRI scanner, and some of these patients are most of them are completely asymptomatic. 40% of people in the ages of 40 will have degenerative discs. The patients in their 50s, 50% are going to have degenerative, 60%. So that's sort of a general rule. So, there's a lot of findings on MRI that are completely normal. People are asymptomatic. Just because somebody has degenerative disc or even stenosis doesn't mean they need any treatment, let alone surgery, right? They need to be symptomatic, obviously, and fail conservative measures, which we'll talk about more of the treatment stuff in a little bit. This is a picture of something called an annular tear. So remember, the outer rim's the annulus fibrosus. Oftentimes, the disc will degenerate, and you'll get a weakness in the annulus, and it'll actually tear. And it's depicted here by a little white dot. On the axial, it'll show up oftentimes as a little line, and typically it happens posteriorly in the disc. So you see it right back here, a little white line. You pick it up oftentimes on the sagittal, though, that little white dot. So an annular tear can cause a lot of back pain, but it can also cause leg pain. And this is a really, really important point that I'm going to make, that is something that might be helpful to you guys to communicate to your patients. There's a lot of patients that come in and they're in a lot of pain. And you get an MRI and it's negative. You don't really see a big disc herniation. You don't see a big slip. You don't see a fracture. You don't see a tumor, right? So you say to the patient, well, your MRI is negative. And they sort of, what do you mean it's negative? But I have all this pain. They sort of go on the defensive like, you don't believe me. This right here is your explanation, potentially, okay? So if I have that situation and I sort of can't necessarily expect, maybe I don't even see that annular tear on the MRI, but it's potentially an explanation to the patient because I can tell them, I can offer them an explanation that could potentially be causing their pain, right? Because I can tell them that when you have an annular tear, this causes an inflammatory response because your body's smart. Your body understands something happened. It picked up that there was a tear. So what does it do? It creates an inflammatory response. All these inflammatory cells, these eosinophils, these basophils, macrophages, they go to the area, right? They're going to that annular tear to try to repair it. It's smart. But what do those inflammatories do? Those inflammatory cells are all over this area. And what's right next to that tear? Nerve root, nerve root, nerve root, nerve root, right? So when those inflammatory cells are all around those nerve roots, that causes a chemical radiculitis. So you can have a compressive radiculitis and you can have a chemical radiculitis. And they can be just as equally as severe or symptomatic, right? So patients' leg pain, numbness, weakness, reflex shade, all that could be caused just as much by a compression neuropathy as a chemical radiculopathy. Spondylolisthesis or instability of the spine. So you can see the posterior aspect. Here, I'll use this pointer here. The posterior aspect here of the vertebral bodies, these all line up, but you can see this one steps off right there. Right? So this L4 is shifting forward relative to L5. So that's called spondylolisthesis. And that's what I'm looking for with those flexion extension x-rays. Now sometimes people have such a big slip and it's a static slip, I mean it doesn't reduce. So no matter what x-ray you take, even if you take a straight lateral, it's going to show up. Or even on an MRI when they're laying supine, the spondy shows up. But if it's a dynamic instability, oftentimes you need those flexion or extension x-rays to have it rear its head. Here you can see the slip right here. You can see the back of L5 in the back of S1. L5 is anterior relative to S1. Pretty significant. That's probably a 4 or 5 millimeter slip. And here you can see this is degenerated. See, it's collapsed down compared to these. And you see these changes, these reactive bony changes in the bone next to the end plate. Those are called modic end plate changes. It's a radiographic finding. So spinal stenosis. So here you can see there's a lot of CSF along the nerves here and here, but it's being pinched right here. The CSF is being pinched right there. So spinal stenosis, stenosis means narrowing. So when I'm explaining to patients, they read these reports and they see stenosis or use the term stenosis, but they don't really, it's hard for them to grasp what exactly is stenosis. I say, so you have spinal stenosis. Stenosis means narrowing, right? You have a spinal canal, the nerves run through it, but your spinal canal is narrowed and it's pinching the nerves. So what's causing that? Well, spinal stenosis can be caused from a myriad of things. It can cause from a disc bulge or a disc herniation. It can be caused from the facets hypertrophying and taking up space in the spinal canal. So that's a picture there. This is a neck. This is a cervical spine. There's a big disc herniation there. The oblong bone is C2, obviously, 3, 4, 5. That's a C5-6 disc herniation with cord compression. So this patient doesn't necessarily need anything. Even though they got stenosis on the spinal cord, they don't necessarily need anything. They don't necessarily need therapy, medications, injections, but we need to make sure they don't have a neurologic deficit. We need to make sure they're not myelopathic, right? We got to keep an eye on them. This patient here is a little different. This patient here, you can see this white signal change in the spinal cord. Okay, that's called myelomalacia. It's edema in the spinal cord. That spinal cord is being affected. There's pathologic change in the spinal cord secondary to the compression. So this is more concerning, obviously. There's change in the spinal cord. Much more concerned about this. Now, the next step, this is myelomalacia, which is a radiograph find. The next thing is when they become symptomatic from this. There's either signs or symptoms of this problem, of the spinal cord compression, and that's myelopathy. So that's what we need to make sure we're finding out from our patients. We need to make sure, number one, do they have neurologic deficit? And number two, are they myelopathic? So the myelopathy is the one that's really interesting. Rudy, who's here, he's my PA in the office, we were just talking about this today. We have this conversation a lot because I always say it. Most of my patients, I don't recommend surgery, or I don't say you have to have surgery. And Rudy can attest to that because they don't need surgery. Surgery for some patients is an option, but and I had this exact conversation verbatim with a patient today. I told the patient, I said, 1 out of 20 of my patients, 19 out of 20 of my patients don't need surgery, never have surgery. 1 out of 20 of my patients, or probably actually less than that, I say, I think you should have surgery. So who is that patient? Because remember, I'm a spine surgeon, right? So people who are coming to me, they've already been vetted out by a lot of doctors or just got better in time or by conservative measures. So I'm kind of seeing the worst of the worst. And yet still, it's very rare that I say, I think you should. So who is that patient? That patient is the myelopathic patient. That patient is this patient with the signs and symptoms of myelopathy. So what are those signs and symptoms? Number one, dexterity issues. Okay? So what are the questions we're going to ask the patient? Are you having difficulty with fine motor movements? Are you dropping things unexpectedly? Are you having difficulty buttoning buttons? right? Those sort of things. Are you getting sloppy handwriting? These are very subtle findings that people don't necessarily relate to a spinal cord problem. Yeah, you know what? It's funny you ask. My handwriting's been getting sloppy the last 6 months. I couldn't figure out why. Or, yeah, now that you mention it, I keep dropping things. Or I can't I'm having difficulty picking up fine things off the table or coins. Yeah, you know what? Every time I button my shirt, it's kind of, it's a little difficult now. So that's number one. The first sign of myelopathy is difficulty with dexterity, fine motor movements of your hands. Number two, gain in balance. That's another thing a lot of people don't always correlate with spinal cord compression. They have imbalance. Yeah, you know what? It's funny, I'll be walking down the hall and I have to grab the wall. I've actually fallen a couple times in the last 6 months. So that's number one and number two, first sign of myelopathy, but people don't correlate with the neck. And what's interesting, those people can look like that on an MRI, and you talk to them about getting the pressure off their spinal cord, and they're the most hesitant or the hardest to explain that to, that they actually need a surgical decompression. And you know why? Because oftentimes they don't have pain. But the patients with a nerve impingement, that hurts. And boy, do those people want surgery. A lot of times I have to say, no, we can't do surgery yet. You need to try to get better with these other things. And they're dying for surgery because it hurts. But they're actually not at risk for paralysis. The two things you can think about when you're kind of screening people in general that have neck and back problems is you want to think of, okay, what are the things I really need to look out for? I would say there's two things that if you want to simplify things. Number one is neurologic deficit. Number two is myelopathy, okay? And the way to think about it is this. Number one, with neurologic deficit, think of nerve root impingement, okay? If I got an L4, big herniated disc, and you're pinching a nerve root, you're going to get neurologic deficit, right? You're going to get a foot drop. Or if I got a C5-6, right, herniated disc, and I got biceps weakened, neurologic deficit. Okay, now I got a nerve root issue that's a deficit, that's more emergent, right? Because they may not get that back. We got to get pressure off that nerve. It's not just pain and numbness in quality of life issues now. It's actually true neurologic deficit. So that's more nerve problem. But the myelopathy is the spinal cord problem, the spinal cord compression. And that's when we're screening for the imbalance and the dexterity issues. With spinal cord compression, you can be hyperreflexive. You can also be hyporeflexive too, though, so don't let that throw you off. Hoffman's is probably the best test for cervical spondylotic myelopathy. So Hoffman's, if you have somebody relax their hand, you want to, it's hard for the patients to relax, as you all have experienced, but you have them, you sort of do this with their hand until you know that they're loose and relaxed. You take their middle finger and you flick it. You flick their nail. So I'm holding their middle finger with my index finger, and I take my thumb and I flick their middle finger. A pathologic reflex, a positive Hoffman's, is they contract their thumb and their index finger like that. You'll see it. If you test enough people, you see it. One reason why you see it is because there's a 17 to 18% false positive with the Hoffman's. So just because somebody has it doesn't mean that they really have spinal cord compression. But it is probably the best test to pick it up. So another is sustained clonus. If you're looking for myelopathy, that's a really good test. Because, okay, so if you have compression in the thoracic cord level, Hoffman's ain't going to work, right? So you need to test something in the lower extremities. So what you do is you take their foot and you forcibly dorsiflex it. So you wiggle it just like I wiggled their hand, but you wiggle their foot to make sure they're totally loose, and you forcibly dorsiflex their foot. And if they'll bounce back with some beats, their foot will plantar flex involuntarily. And if it does it 2 or 3 times, that's normal. But if it does it, what we call sustained clonus, they do it 6, 7, 8 times. Get an MRI of their neck and their thoracic spine. Looking for cord compression. So, again, the systematic approach, right? Good history, good physical exam. You want to run through the imaging, X-ray with dynamic films, MRI. What are our treatment options? Let's get these patients better. If they don't have true neurologic deficit and myelopathy, which is 98% of the patients still, then we want to get them better with anti-inflammatories, muscle relaxants, some non-narcotic pain medications, or if they fail all those, maybe even narcotic pain medications. Acupuncture, chiropractic care, physical therapy, TENS unit, some light bracing, not prolonged bracing because their muscles will weaken if you brace them for too long too. And if they fail all that stuff, maybe surgery if they have, for me, if they have a mechanical problem that I think I can make better with a surgical procedure, significantly better, then that may be a treatment option for them. So again, the conservative measures. So some of the things I already talked about. A lot of the injections, we can really nowadays pinpoint where the problem is with these injections. Epidural steroid injections, facet injections, rhizotomy. So rhizotomies are where the pain doctors, they burn the nerve, the medial branch nerve. After the nerve goes out, there's the dorsal root ganglion, and then there's a branch that comes off and it innervates the facet joint. Well, if the pain doctor does a medial branch block, puts a little steroid or anesthetic there, and they get good back pain relief because their facet was the source of their pain. So if we block the nerve that's innervating that arthritic facet joint, they get pain relief, right? So, okay, it's a painful facet. So they block it, it got them better, that's the problem, and then they can go in there and burn those nerves, and that can give patients, prolonged or sustained relief oftentimes. Now those nerves can regenerate, so it could come back, but it can, people who are bad off, it can provide them with 6 months, a year, or maybe even longer of pain relief. So pain mapping. So we have a back like this. This is a pretty common back for, somebody in their 60s, okay? We got 2-level degenerative disc disease. We got spinal stenosis, at least here and likely there. And we got a spondylolisthesis here. You see the back here is stepped off from the back of L5. So we got 2-level degenerative disc disease, we got 3-level spinal stenosis, and we got a spondylolisthesis. So where's the pain coming from? This is what makes treating backs so complex and so difficult. Where's the pain generator? That's the number one question that is so elusive for us. What is the pain generator here? Is it this disc? Is it this disc? Is it the instability at this level? Is it the stenosis here? Is it the stenosis here? Is it 2 of those 5 problems? Is it 3 of those 5 problems? Well, which ones? They failed everything. Well, what are you going to operate on? All of it? One of it? That's where pain mapping can help a guy like me and the patient. Because we can say, for example, I can say, well, their pain pattern is this. Why don't we do a selective nerve root block to block this nerve right here? That didn't help them. Okay, well, let's block this nerve. Wait, that gave them 100% pain relief. Now we can focus a procedure just on that nerve. Instead of fusing 3 levels, we can just do a laminoforaminotomy to free up that nerve right there. So what happens when the patients have failed all these conservative measures, right? That's when I'm talking about the 95 or 98% of the patients, right? We're not talking about the myelopathic patients, right? So most of my patients, 19 out of 20, fit into this category where they're not myelopathic. Now, I would say probably 80% of those people, we get better with the medications, the conservative measures, therapy, injections. But what happens to those about 15% of my patients that I see that are resistant or refractory to all those conservative measures? But they have a structural problem that I can identify, that I think I have a high level of confidence that I can make them significantly better. Then I have this discussion with them. You failed all the normal treatments. You have this problem. This is the procedure that we could do, but now it's not, you don't have to have surgery. This is a quality of life issue, okay? They're not at risk for paralysis. They don't have a tumor. They don't have cancer. So they could live with it. So I tell them that. You can live with this problem. You could live with it, or we could do more conservative measures, more therapy, more injections, or we could do this procedure, right? And so what is that procedure? Well, we'll get into the nuances of how I select a procedure, or what options are available nowadays, which are much different than they were 5-10 years ago even. So the first thing I do with those 15% of patients in my mind when I'm thinking about, well, let's say they do want surgery. Well, what surgery is it that I'm going to do or going to offer them? The first thing I do in my mind is I'm trying to decipher, do they need a non-fusion, a decompression, or a fusion? So typically the non-fusions or decompressions, which would be like discectomies or laminectomies. So discectomy, they got a herniated disc. I make a little window in the bone and we take out that disc and their leg pain's gone or much improved. Laminectomy, they have spinal stenosis, we free up the nerves, right? Those surgeries can all be done minimally invasive with a tube, with an endoscope, with a laser, and they're very effective. And the patients go home the same day, minimal tissue disruption. Patients, though, where their pain generator is that bad disc, degenerative disc. The problem isn't a pinched nerve. The problem is a bad disc, or the problem is the instability, the spondylolisthesis. Well, no cute little decompression is going to help that problem, unfortunately. And so that's also difficult to tell certain patients that they've done their research on the internet and all they want is a minimally invasive this or that, but unfortunately their problem is such that they actually need a fusion. Fortunately, over the last 5 or 10 years, we've really gotten a lot better at doing minimally invasive fusion procedures that I'll show here with incisions less than an inch long to address these problems. After I decide, okay, they need this surgery, either a decompression or a fusion, then I said, well, they need this surgery, but it should be minimally invasive or it should be open or traditional. They need this fusion, but it can be minimally invasive. So I figure out if I do it open or because there's about 10 to 15% of my patients that the best surgery for them is an open surgery. So I still do open traditional spinal surgery if that's the best surgery for the patient, for their pathology. But fortunately, 85% of my patients, I can do minimally invasive surgery that achieves that exact same thing, but the technique is just minimally invasive. And so what that means is that spares their tissue, spares their muscle, their ligaments, their tendons. There's less blood loss, there's less anesthesia, there's less operative time, there's quicker recovery, there's less chronic pain. They return to work faster. Muscle is motion. The name of the game in minimally invasive surgery is to spare tissue, spare muscle. Let's keep their function. When you cut muscle, it does not heal. Muscle scars together. They will lose for the rest of their life the function, the maximal potential of that muscle. There's a picture of an open surgery. We have to strip all the muscle away in an open traditional surgery, right? So I can look right down on the spine and find my bony landmarks. So I can do my work. Traditional open surgery, minimally invasive surgery. Minimally invasive surgery can be done using fluoroscopic techniques to pinpoint exactly where we need to place our instruments to do a discectomy or place a screw or whatever it is we need to do. There's an evolution of minimally invasive surgery. Not all minimally invasive surgery is created equal or is equal. So here's a technique here where there's a smaller skin incision, but the dissection or the tissue disruption underneath the skin incision is much bigger because they put the tube down and then they spread it apart underneath the skin. So to a patient or to somebody else who just sees a skin incision, say, well, that's a pretty small skin incision, but what happened underneath is really what I'm concerned with. How much tissue was disrupted underneath? Was that the technique? Or was it a different technique that I'll show you in a minute? Well, fortunately, we have high-powered microscopes right now, $200,000 a pop, and we have specialized instrumented, bayoneted instruments we're called, right? Because this is a bayonet. So when I stick my hand down this instrument down a tube, which is very small, say 1/2 inch in diameter, my hand isn't blocking my view, right? Because it's offset, it's bayoneted. This is the way we do it now. We put down small dilators first under X-ray. The first dilator is smaller than a pencil or about the size of a pencil. So I localize, say I'm operating at L4-5, I got a herniated disc at L4-5. I take a lateral X-ray, I see where L4-5 is, I make a small skin incision, I put the pencil-like dilator through the tissue that just spreads the muscle fibers just slightly so the pencil can get down and it docks right on L4-5. Then I slip a slightly larger diameter dilator over top of that just spreads those muscle fibers just a little bit more. And then a little bit more until it gets to about 1/2 inch, about 18 millimeters. And then I pull out the inner ones and put and now I just have a working channel through the middle that I can look down with my microscope or my loupes and my bayoneted instruments and my headlamp, and I can see and I confirm it under X-ray. So I don't need to strip away 3 inches above and 3 inches below. I know right where I'm at by that X-ray. And I could do all my work through that little portal. Through that same incision, we can even do a level above or cut across and do the contralateral side too. So I'll dock it in off of, say, one side of the spinous process, but if they have pathology on both sides of the spinal canal, I can just lean it over like that and cut across to the other side. So here you can see that where you're cutting across. So here the dilator is going in on one side. You can free up all the nerves on this side and then angle it and cut all the way across and get out into the foramen on the other side. So even as a resident, as an orthopedic spine resident, when I first started reading about this, I didn't even believe it until we started to do it. I said, you can't do that. You can't manipulate the nerves and cut across on the dura like that, but you can. What's the difference between laminotomy and laminectomy? Laminotomy is just one-sided, a little hole in the lamina. Laminectomy is full laminectomy. We take all the lamina and spinous process out. These are decompressive techniques to free up nerves. So minimally invasive procedure, so we could do anything from a simple discectomy all the way up to multi-level fusion with this minimally invasive technique, big and small. So here's a discectomy. Here's the herniated disc. We put the tube down. I make a little window here, and I pull out that disc, pull the tube back out, and they go home. So you can use a laser. We can go in here and just shrink the disc or burn the annular tear. Here we can use an endoscope with a little camera to actually visualize the disc. This is for spinal stenosis. There's a little spacer that goes in between the spinous process, and what that effectively does is flexes that segment forward. So flexion in the lumbar spine increases the canal diameter. A little bit of flexion can increase their diameter enough to make them not symptomatic anymore. Who are these patients that need fusions, right? That's kind of the word that's tough for patients and us to get our heads around, right? A fusion, we don't want to do fusions. But sometimes that's the right surgery for the patient. The best indication for a spinal fusion, or one of the best, is spondylolisthesis with spinal stenosis. You got instability. There's no decompression that's going to make that better. In fact, the decompression makes that worse, right? Because they're already unstable, now you're destabilizing them more, and they got pinched nerves. So you got to decompress them. You're decompressing an unstable spine. They got to have that stabilized. No way around it. Degenerative disc. You can't decompress a degenerative disc. The disc is painful. So you got to take out the disc. You got to take out the disc, you got to stabilize it, you got to fuse it. So those are the two major indications for, other than deformity, scoliosis. So again, there's the picture of the big open surgery. Here's a minimally invasive surgery where I did a fusion through 2 incisions the size of a quarter. Same surgeries through the incision the size of the quarter. That's the traditional open surgery, 6 to 8 inches long. Here's a penny. This is our minimally invasive surgery to get all that accomplished, either through that or that. Same surgery is going to get done. They're still going to get a cage and screws and rods for their instability and stenosis, but you can see how dramatically different the approach is and how dramatically different their postoperative pain would be, their muscle disruption, their blood loss, their hospital stay, etc. There's certain instances when we want to, as surgeons, they have so much instability that we actually want to stabilize them more than one of the smaller cages from the back. We want to get a bigger graft in for more stability. It's a biomechanical issue. Surgery of the spine is very biomechanical. So now I have an unstable spine. I really want to get a big structural graft in there. When you go through the belly, which I still do sometimes in certain instances, like at L5S1, where I can't go through the side like this because of the iliac crest, I can't get there. We have this new technique called an XLIF. I'll never forget the first time I heard about an XLIF. What the heck is that? So what you do is you make an incision on the side 1 inch long. I go down in the retroperitoneal space and I develop it with my finger. I put a probe down there because there's a lumbosacral plexus that's running across the psoas muscle. The probe tells me I'm out of the way of the nerve, or I move the nerve out of the way and I dock off the disc. I take out the disc and put in a big graft all through 1 inch skin incision in the side. A week ago, Monday, I did 3 big grafts, 3 levels through 1 inch skin incision right here. If you try to do that through an anterior approach, they'd be cut from here to here. And you risk their aorta and vena cava. So here's an intraoperative depiction of that. 1 inch skin incision there. Dilator goes down under x-ray. I know exactly what disc it's on. I put my neuromonitoring probe. I know the nerves are out of the way. I dock my tube. I take out the disc and I put in a spacer block all the way across that disc space. This is just a depiction of how I put my finger in there to locate my location. So by finger palpation as well as x-ray, because I need to develop the retroperitoneal space to move the colon anteriorly. I put in the probe to make sure the nerves are out of the way. The machine tells me the nerves are out of the way. So here's the preoperative film. This patient had a prior surgery. But look what happened. They collapsed up above. So this is very common. So when patients worry about it, they do the research. They say, well, but if I have a fusion doctor, aren't I more likely for the next level to wear out? And this is what I say. Yes, you are. However, we also don't know, and these are the things that when I get together with my colleagues, with other spine surgeons at meetings, we sort of debate about and argue about. Would that patient have broken down that level had they not had the surgery? Hard to say. Hard to say. But one would think if you did an open surgery and you stripped those muscles and those tendons a good segment or two above where they did this surgery, you're probably more likely that that is going to break down, right? So that's another reason to do the minimally invasive technique, to preserve those adjacent tissue structures so that you don't compromise the adjacent segment stability and make it a greater likelihood that they develop this. So when they do develop this, what I did was I did a lateral. I made a 1-inch skin incision. I took out the disc and put in a spacer block, and the screws extended up. So now you hear they have the spondylolisthesis here, they're realigned. So scoliosis. So this was not a minimally invasive surgery. So some people, like I said, we can't do everything minimally invasive. There's a situation where it doesn't make sense to do it minimally invasive. This person has a scoliosis, structural, and you need to just stabilize their spine and correct their deformity and hold it there. If you see a kid, a pediatric patient, and they're not of skeletal maturity yet, when they get to 20-degree curve, you need to start bracing them. They should be referred to a pediatric orthopedic surgeon. You start to brace them because you want to hold their curve to less than 50 by the time they reach skeletal maturity. That's a number we know by many studies across tens of thousands of kids, because if you hold them to below 50 by the time they reach skeletal maturity, as we followed them throughout decades, we know that they're less likely to progress their curve. If they hit over 50, when they hit skeletal maturity, they're more likely to progress, and they typically progress at 1 degree per year. So what does that mean? You got a kid who's 18, he's progressed to 55 degrees. Let's say he's 20 years old and he's 55 degrees. What happens when he's 50? He's 85 degrees, okay? The other number you want to keep in your head is 60 degrees. When you got a curve over 60 degrees, you get cardiopulmonary compromise. Yeah, that's a Cobb angle. When they get over 90 degrees, you have increased mortality. So 20, you start bracing kids. If they're over 40 degrees as an adult, they need surgery because they're going to progress. 40 to 50 is kind of the range, 40 to 50 degree. So in summary, back pain is very common. We need to ask patients, we need to look out for the big red flag things, right? Neurologic deficit and myelopathy. Remember, hand dexterity issues and gait and balance. We need to do our proper workup, physical exam, motor strength, sensory, reflex changes, right? The Hoffmans, the sustained clonus, right? We want to get our dynamic x-rays and our MRI. And 9 times out of 10, we can get those patients better with time, anti-inflammatories, chiropractic care, physical therapy, injection therapy. And when they fail all that, we might have a surgical solution as an option for them. Thanks a lot.